Happily, babies admitted to the Neonatal Intensive Care Unit or NICU seldom need to undergo tracheostomy. But when the RCPs and nurses who practice in the NICU encounter such newborns, they are confronted with a variety of therapeutic challenges. This 48-minute module discusses a broad spectrum of issues related to tracheostomy care in the neonatal nursery. I created it when I was a clinical specialist at Stanford Children's Hospital and subsequently served as the Regional Respiratory Care Education Consultant for Southern California Permanente Medical Group in Pasadena. The module begins with a description of neonatal airway anatomy and specifies the distance beyond the tracheostomy stoma the tip of the tube should reside. The site within the adult airway that exhibits the smallest collective cross-section is the vocal cords, but such is not the case for infants, as explained in the presentation next. The attributes of a so-called tight-to-shaft tracheostomy tube are outlined, and RCPs might be inclined to approach their physician colleagues to select a particular infant as a candidate for this type of appliance for reasons that are enumerated here. The module compares and contrasts the typical category of trach tie, fabricated of cotton twill, to a trach tie fashioned from small bore suction catheter material. The latter type of tie is used at Stanford Children's Hospital and has won favor with nurses and RCPs there in recent years. The full-page version of a hard copy diagram describing the safe suctioning strategies incorporated in the module's handout, and learners can, if they choose, deploy this graphic at the bedside of tracheostomized infants. RCPs in some institutions are authorized to insert and extract tracheostomy tubes, and the module outlines specific measures that should be routinely employed when doing so. It is universally recommended that a spare trach tube be kept at the bedside of tracheostomized patients in the event of unexpected decannulation. The issues surrounding this practice are explored in detail. The practice of applying a double-layered dressing to a freshly incised trach stoma is explained here, together with the anatomically based explanation for extreme caution when reinserting a tube following replacement of a tube that is discarded. The presentation concludes with a video-enhanced, step-by-step description of the tracheostomy replacement procedure that, in some medical centers, is routinely undertaken by RCPs. Some preceptors have used this portion of the module to prepare frontline RCPs for their return demonstration exercises. Many RCPs rotate assignments between the neonatal intensive care unit, the pediatric intensive care unit, and various adult ICUs. Although this module pertains specifically to neonatal tracheostomy, various portions of it apply equally well to tracheostomized children and adults.